Good afternoon, everybody. Thank you for joining us for the 3:30 session. I think Dr. Siraja said he was going to go out and corral more people and get them in here, so we'll get started here. I think we got a great lineup of ultimate mitral cases, not just regular mitral cases. These are ultimate mitral cases, so that should be entertaining. I'm joined by my co-moderator, Dr. Firas Zahr from Oregon, the good Dr. Steve Bolling. How are you doing, sir? Dr. Brannon Hyde, who just did a 3-vessel cabbage and came over here to join us, which is fantastic. Dr. Little and Dr. Sodhi. So I think this new kind of format is fantastic, and we're going to start off with Dr. Joao Cavalcante, who's going to talk to us about innovations in mitral imaging.
Well, thank you very much. I really like this format because it makes you walk as well and talk. And I hope that over the next 10 minutes we talk a little bit about how innovation on imaging for the mitral valve might be important. I don't have a clicker here. I don't know. Should I say just... Oh, here we go. Thank you, Steve. All right. So, thought about dividing into 3 topics. First is how can we continue to improve the TEER results, improving patient selection, improving procedure results, and talk a little bit about mitral valve disease associated with MAC. There were great cases on the press session that you heard about mitral calcification and the challenges of treating that patient population. And then how can we increase TMVR legibility? So this is a graph that you probably have seen already and familiar with. Not only whenever we do more, we do better, because we learn from our mistakes or mistakes from others, but there's certainly a case relationship here with procedural outcomes. The more you do, the better you become. The problem is how can we scale that? And despite the best efforts in the procedure success and the understanding of mitral valve disease, we can still see that up to 20%, 25, 30% of these patients still are left, despite adequate results initially or post-procedure, still have residual mitral regurgitation. This has improved, obviously, with the development of new generations of devices and also under the understanding of the imaging and procedural imaging. And this is a slide that I borrowed from my colleague Paul to tell us that actually when we talk about edge-to-edge repair, it's not just about approximation, but it's actually restoring what we call the coaptation, which is obviously the collection and the contact of these 2 leaflets. And that contact needs to be actually measured. And that contact, it's important because when we place a repair device, the more contact that you have and the longer that coaptation length, what we call in here coaptation reserve, is going to be much more associated with the outcome. So the greater the coaptation reserve, the more length that you can approximate these 2 leaflets, and the more the augmentation that that device is going to provide is going to associate with the procedural results. So in this case series that we did, and of course to study this you got to be pretty much consistent, so we excluded multiple clips. We just went with the A2P2, so 180 patients, and you can see on the top graph there that the greater that coaptation reserve, the lower the residual MR, the greater is going to be the procedural results, and obviously the patient outcomes. So can we measure, can we predict that? Can we identify and selectively address that beforehand and augment that? And obviously this is a moving target because the devices are getting better and our imaging and understanding. And this is just a representative TE imaging for a patient that would be optimal, that you have a nice coaptation reserve. After the clip, you approximate these leaflets in a patient that has a much dilated annulus, a much more greater tethering degree. And this is not different from what we had already seen with the surgical data. This is a meta-analysis looking at patients that had degenerative mitral regurgitation. The greater that coaptation length, and here is obviously a continuum, so worse if it is less than 7, better if your coaptation gets up to 10 to 11 millimeters, you will leave with less residual mitral regurgitation, potential durability of that. Now let's talk about not the MR now, but FMR. In FMR, we know obviously the results of the COAP trial, but we still have in this analysis done by Paul Grayburn at the 2-year follow-up, 54% of the patients that received mitral clip were considered to be non-responders. That is, either they died within the 2 years, they had heart failure hospitalization, there was actually decrement of their KCCQ change. What could that be? And you can see on the bottom left there that the black bar is actually associated with the residual mitral regurgitation that we just talked about. But is that just that, or is that also related to the patient selection that we need to continue to improve? We say that FMR, the problem is not the valve, but it's the ventricle. But do we understand that ventricular disease entirely? Do we understand what is the significance of that mitral regurgitation in relationship to that contractility and the scar that these ventricles will have? And that we can measure. We could argue that you could probably assess that by echocardiography. Yes, when the walls are thin and scarred and they are akinetic, you can do that. But the quantification of that, not only by volumes, but also by the scar, might be important for these patients. And here's a case example of a patient of ours that had a clip 3 months later, presented with heart failure hospitalization. You can see the artifact from the clip, but you can see here in the yellow arrows the scar that was measured up to 21% of the scar of that left ventricular mass, as well as increase on the interstitium. So this patient obviously is relapsing because of the disease of the ventricle. And now, obviously, we have new armamentarium of GDMT that we could consider to treat. And this is the framework that I think we need to consider in some of these patients. The patients that have a lot of scar and patients that have a lot of MR, you could try GDMT, but don't keep your hopes up. You might try to help them. In fact, GDMT in these patients is really hard to push up. And maybe by treating them MR early on might be of benefit to these patients in adjunction to that. Now, Mac, you heard that from the prior talk, two cases of post-TAVR. Right, so this is a series from Edinburgh. They were looking at the calcification of the aortic valve, but MAC is common in these patients. And what they basically showed is that the mitral annular calcification progresses over a period of 2 years. It's a biologically active disease, and that is the challenge when we treat in the aortic valve, and these patients have mitral valve disease. Can we predict what is going to happen to the mitral valve down the road? Mitral annular calcification is associated with other comorbidities. As we heard before, pulmonary hypertension is quite difficult, and sometimes these patients might have, obviously, atrial fibrillation and other valvular disease on the left side as well. The assessment of the degree of stenosis in these patients is difficult, and we cannot use what we heard and we learned from pressure half time, for example, when dealing with rheumatic mitral stenosis, because of this tubular orifice as opposed to a funnel shape. And in patients that are getting treated with AS, up to 25% will have some degree of mitral annular calcification. So can we do better to understand that? And that's, just a really nice review that came out last year from Jack, highlighting some of the difficulties in trying to assess what should be the methodology. And I believe that actually combination of both CT and echo will provide us this more granular detail that we need to understand which patients do we have a little bit of time that we could try to treat the aortic valve and then eventually address the mitral valve, or when are these patients that we need to address both simultaneously. CT can provide this calcification quantification by volumes as well and segmentation. And treatment of this mitral valve disease, as you can see on this video, is quite challenging because it's not only annular, but it's subvalvular as well. So it extends into the myocardium. And the fixation of that prosthesis requires this circumferentiality. Wow, that's quite of a mouthful word here. The more calcium you have, the more distributed that calcium is, the thicker it is, the greater it is for you to anchor and prevent embolization. But oversize is important, and device specifics are going to be important in these patients. The other point that I wanted to make as well is that MAC is not just a disease of the mitral valve, but also of the sickness of this patient. This is treating with, obviously, a device-specific tendine. During COVID time, you can see that the 1-year all-cause mortality was up to 40–50%. You could say that, if they don't get treated, it was probably going to be higher. But we're still dealing with a patient population that we deserve a better understanding of what is the impact of this mitral annular calcification into the muscle, what is the importance of that into the left atrial stiffness, lack of compliance, etc. And eventually, we need to treat these patients. Now, to treat these patients, it becomes another challenge because they typically don't have space, right? The ventricle is already hypertrophy is small. LVOT obstruction is really high. And you have to iterate and you have to consider how we're going to allow more treatment of these patients. Device specifics like the tendine, and you can see here the blue, or teal, I should say, light blue and yellow, the teal being the smaller, low profile, allows for obviously a smaller valve, but allows for the treatment of a greater number of patients. This is just a recent case example from our hospital, a patient with a very small coaptation reserve, as we talked about. The jet goes all across the coaptation line, mitral inlet calcification, and you can see significant mitral regurgitation with a mean gradient already of 4. This is the CT, showing the same situation here. You see the posterior mitral inlet calcification and the lack of coaptation of this leaflet. This is a left atrial view, surgeon's view, left atrial appendage. And this is from the left ventricle. You can see the coaptation, lack of coaptation across the entire coaptation line. And you can see mitral inlet calcification. This was too large for a potential sapien device. And we looked into a potential for Tendyne. And as you can see here with Tendyne, it would fit both for the standard profile and low profile. And you can see the difference when you do an STL, that's with the standard, this is with the low profile. But what if we get away from the left ventricle and we fixate that valve into the left atrium? That's the other concept of the outer valve that now can treat a greater number of patients, and we're going to be talking a little bit more of that in the upcoming TCT. And as you can see, it preserves the natural motion of the mitral valve. In systole, the anterior leaflet tries to close, differently from any of the other TMVR devices that tries to keep that leaflet open. So the systolic area is larger than the diastolic, which is actually what happens into all of us. So in conclusion, I think CT and echo and CMR in certain patients can provide this aggregate understanding of the ventricular disease as well as the mitral valve disease. We need to continue to understand better this mitral inlet calcification population because they represent a vaccine problem. Difficult to understand the significance of both valvular disease and how to treat. And it will be nice to see what the devices will iterate and also consider surgery. Not all the patients are prohibitive of risk. We still need to bring them on board. Thank you.
Thank you, Joao. So I guess one of the things that's intriguing to me, and I don't know what the thoughts from the other panelists are, is this concept of the myocardial fibrosis and concomitant mitral regurgitation. How do you address those patients clinically? I can imagine scenarios where you have patients with severe MR, they're symptomatic, and they have a certain degree of fibrosis. I mean, are you saying we shouldn't treat them right now, or just consider that they're going to treat them, but they're going to have recurrent events? You're going to have to try to follow them a lot closer than you normally would.
And no, thank you for the question. No, I don't think that the message should be that we should not treat them. I think the message should be that we need to better understand where do they fall on that spectrum. And some patients actually that don't have a lot of fibrosis, GDMT might work miraculously. It works quite well, and we should progress them, and we've seen that. And there are some patients that we need to have the concomitant help of the clip or whatever the therapy device for the mitral regurgitation is. But there are patients that might be, and that might be some of these mitral FR patients, that the ventricle is pretty much gone. You might gain some benefit of symptom relief, but the long term is already determined up front. So what you do in these patients, and I think that's when we need to continue to bring in the heart failure specialists. Heart failure therapies are also changing. So now we have better armamentarium for that as well. And also heart failure therapies are existing now to support that ventricle. So I think it's that refinement that I think we need to continue to better understand, but not to decide don't treat these patients.
Yeah, I'll just follow that comment. I mean, the notion of relative risk reduction and absolute risk reduction, that's what we're all struggling with because, if these severe FMRs with lots of scar have a 1 year relative mortality of 60%, and you reduce that to 30, you feel great, but that's still a 30% mortality. I think that where is the futility is where we're having a hard time. And scar helps. Improved devices are going to help, but I think that's where the work has to be is the futility.
Yeah.
I mean, one of the things we think of as degenerative disease, they have one problem, it's a mechanical problem, you fix them, you fix the patient, done. But FMR patients have 100 problems to them, and one of them is MR, and you fix the MR, they still got 99 problems. And if this can help us predict which ones we can push forward with getting rid of their MR, then that's really helpful.
Yeah, and that threshold of scar also might be different from a transit TMVR versus an edge-to-edge that is so elegant. You go in and out, you don't cause cardiopulmonary bypass, cardioplegia like a surgery would do. So that threshold we need to still define and to continue to improve. What are the patients that we need to go up front and support that?
I guess, it's hard to get every patient undergoing I mean, these days, when we see patients, we can get a CT scan, we can get a transthoracic, and we can make a lot of assessments about how to potentially treat them. The concept of cardiac MRs and getting them frequently or getting them at all for a lot of our patients is a challenge right now in terms of resources. So are there any, is anybody aware about maybe using strain to kind of identify patients that kind of may have, I don't know if viable is the right word, but kind of, not scar, but you know what I mean, like whether it might be a viable alternative.
Yeah, what would be the surrogate of that, right? So yeah, strain measures the deformation. It's close to the scar, but it's not a surrogate for that, especially the diffuse fibrosis. So strain in a territory that is scarred is going to be quite abnormal and low. So it could help out in that prediction, but will not substitute for that. I would say that access to CMR is continuing to improve. I mean, I think it requires obviously passion and who controls that schedule and how can we work along with our radiology colleagues. Cost should not be the excuse. The cost of an MRI is actually cheaper than doing an echo with contrast, with bubbles. So I think it requires, obviously, sometimes these patients have devices, it requires some programming. So yes, there is a little bit of more than just getting an echo, but I think the information that is provided, the quantification of the volumes, and the regurgitation, the scar, all of that would add up to the story.
So just switching gears to Mac, Brannon and Steve, you guys love operating on Mac, I know you guys enjoy it quite a bit. The issue, despite having all these imaging capabilities, is really the screen failure rate for any sort of therapy we can offer them right now. It is magnificently high, and then on top of that, the prediction for the LVOT, while it still continues to get better, is still fraught with a lot of limitations. So what are kind of some strategies or upcoming innovations, AI, that can help us kind of mitigate the uncertainty here?
Yeah, so lots of thoughts here. So first, the mitral calcification in terms of predicting suitability for TMVR, I completely agree with you. We know that this is one of the Achilles heel, right? And what I highlighted to you here was a potential opportunity that for us that consider the fixation of that device actually in the left atrium. The first time that I saw that, I was like, it makes no sense. But, seeing screen failures after screen failures, and some of that is screen failures to have to do with our threshold for selection being too conservative. And that has to be with the way it was set from up front. When we do a simulation of the LVOT, we simulate that device to be completely expanded without any constraint. And when we put the device into a Mac, that device is going to constrain. And therefore, that prediction is going to be much smaller than what truly happens. So we're screen failed probably a larger number of patients that could potentially be treated. That's why we need to continue to iterate. And I think that is a work in progress, and a lot of the devices are now starting to consider the application of post-imaging CT, particularly to see if we can refine or do other methodologies to improve that.
Yeah, Joao, this is a fantastic overview of imaging. I tell you, I remember, I remember this every time you look at the longer term mortality for mitral intervention. Whether you look at the TVT, 2-year all-comer mortality, whether you look at TMVR trials, 2-year mortality, I mean, you see that number of 20-25%, popping up, which is very high mortality rate for for procedures that we do, and it actually is not a lot of difference between TEER and TMVR once you go up that far. I mean, the question is there anything that we can do with the imaging modality that we have in hand to predict who are those patients that, maybe we should treat more of those who are going to respond with TMVR and less of those who are not going to respond? Is this medical therapy effect? Is this MAC effect? If this is a therapy-specific effect, it doesn't look like it.
That's a great question and very provocative, Firas. We were just actually sitting here and showing how great the procedural results was for that valve MAC. I think the last 5-10 years have taught us a lot about, can I do this safely? Can I get this patient out of the procedure room? And now we're discussing this here, right? The metric is going to change because it's not only getting the patient out, it's how can we make this patient, obviously identifying this problem earlier so they don't come with 15 other things, and by fixing one, we hope that we're going to fix everything, right? So that's one recognition earlier. And that comes on us as well as cardiologists to identify and refer. But also, what can we do to support these patients along the way? And that you cannot try to achieve different results by the same methodology. That's insanity. Right? So you have to, can we understand the spectrum of that disease, but not only looking at the mitral valve itself, but what is the constellation of other findings? Staging has helped us to understand AS, has helped us to understand mitral valve now. If we need to look into the ventricular disease, how bad is that ventricle? How bad are the other components that we can help along the way by doing the procedure and other things in conjunction? I think that's what we will need to take a step back to understand forward.
So, I mean, one perspective is that we are doing these procedures on patients who are supposed to be high or prohibitive risk. And the perspective is that, look at what we did with TAVR. When TAVR was restricted to patients who are high or prohibitive risk, the one-year mortality, does everybody remember this from the PARTNER 1 days?
30-something.
25 to 35%. So it's, if you've got a high-risk patient who people don't want to operate on because of illnesses, you're going to have that mortality range. And so that's where all the work in mitral is currently focused in terms of a transcatheter approach, apart from the intermediate risk trials. Until we get away from those high-risk patients, we're going to see these mortalities, despite our initial procedure success. So I just wouldn't get too hung up on that. The therapy needs to develop and mature to where we can feel comfortable allowing it in lower-risk populations. But until we do, we're going to have these mortalities at 1 year.
Completely agree, and I think that's what, the segue for your question, Firas, is that now we are able to get these patients safely out of the operating room. Now the question is, as we expand to a lower risk, what else do we need to consider as well, not just the index procedure? Yeah.
Well, thank you, Joao.
Thank you.
That was great. We're Paul, with your permission to inch it up compared to the last session, we're going to name the cases for this session the most ultimate mitral cases. And just to reward those who stayed with us for a late afternoon. And I'd like to introduce Moody Makar, who is going to be discussing a complex repair of a complex mitral valve disease. Moody.
Thank you, everybody. I'll jump quickly into the case here, my disclosures here. My patient is a 52-year-old. I think this is going to win the youngest patient of the day for today. Recurrent admission with shortness of breath and severe MR. She is on home oxygen, obesity, smoker, hypertension, AFib. Previous mitral valve repair and tricuspid repair annuloplasty in 2015, complicated with sternal wound infection. She had a redo surgery 2 years after that in 2017 that was aborted due to poor visualization of the tricuspid and annulus. And yeah. For the redo part? Or which part?
No, the aborted because they couldn't see it?
They couldn't. So according to the report, what was happening is that there was a lot of blood in the field and there was a lot of scarring in the septum, and they were concerned about an injury that they decided just to abort. And that was unfortunate. Yeah.
Steve, complication happen in surgery as well, not just interventional.
Thank you. And,
Sorry, I'm so sorry.
No, it is a very interesting case, and it's a very good open for discussions because it has a lot of technical teaching points. So she's on long-term oxygen requirement, inability to lie flat, typical orthopnea with 3 pillows that you would read in the textbooks. Turned down again to be done 3rd time surgically due to the multiple sternotomies, obesity, and previous failed procedure, and referred for transcatheter options. And we started by the echo, and as you can see here, there is a nice dehisced ring and a valve in between. And when we put it assessment quickly, you can see there are multiple jets coming from the dehisced ring through the TE. So we planned to do a tear with a mitral clip, and as we can see here from the bicommissular view here, that there are 2 jets according to the arrows here. There are 1 medial jet and there are 1 lateral jet, making it even more complex with a dehisced ring that you can see is sitting inside the valve. So the challenges that we acknowledged is that there are two jets distant from each other. How can we navigate the system with this dehisced ring in just sitting in where we want to go? And how can we even visualize and the shadow from the ring, where to grasp? So we started with the first clip. We wanted to make our job easy, so we picked an NT, G4 NT, and we started to go to the medial jet where we have just posterior to the ring, we were able to see it. And luckily, we were able to get a very good visualization, and I would like to echo the same comment that Joao made about that we are trying to restore the leaflet coaptation here. So it's very important to see the leaflet. It's very important to see both of them sitting nicely and closing nicely, not to be biasing to one side or the other. So after a successful first one, the medial jet is reduced a lot in color, but we notice the lateral jet is now getting worse and worse due to the fact that it was a flail, and now that's the only part that is leaking from. So the discussion that we had is that, should we stop here? We achieved some MR reduction. Should we consider this a successful procedure? And especially that the second jet is far away from the first clip. Are we going to create multiple orifices? And with the creating of multiple orifices is going to be creating MS in this patient. Or the other option is we should try to attempt it. And if there's no significant reduction in the MR, or if there's a high gradient, and this is one of the beauty of this procedure, is that we can abort and take the clip out, and we just leave the patient like that. So fast forward, of course, being at Cedars, we did the second clip, and again, we used the G4 NT towards the lateral jet, and you can see here that we had a very good visualization to be able to steer it, and you can see how close is the interaction between the clip delivery system and the ring it is. And despite that, we're able to get a very good reduction. You can see on the fluoro screen here, where is the ring, where are the two clips that were placed. And the final result that we had is this mild MR with a mean gradient of 5 on TEE. And it was confirmed on the next day with a TEE with a mean gradient of 5 and also still a mild MR. And more importantly than that is that the next day, the patient immediately was in tears of joy as she slept flat for the first time in 3 years. She discharged home without discontinuation of the home, with the discontinuing the home oxygen. And the 1 month follow-up, it was during COVID time, so we couldn't get a transthoracic echo, but she feels really well. She has no limitation to think. She can walk uninclined, no symptoms, less edema, and lost 6 pounds. So the key learning points here is that the TEER is a safe procedure, even in the sickest patient with the most complex anatomies. Advanced steering and techniques can navigate through the complex anatomies to achieve very good outcomes, and consider TEER as an early option versus a last resort when everything else fails. Thank you so much.
Well, thank you, Moody. That was fantastic. I feel it's a career suicide for me if I did not let Steve comment first on this case.
Now, in terms of imaging, I think what you really needed to image in this case was a better surgeon. Because, I mean, this was a dehisced ring. She needed to have another operation. Although, I have to say, we have done this. We have done this from a dehisced ring. We have gone and clipped it, and it worked just fine, just like this. So congratulations, but be that a case, I have never in my life, heard of somebody who couldn't see the mitral valve. So I've done about 7,000 mitrals now, and I've found that it's between the left atrium and the left ventricle, almost always.
There's something. Again, it was very unfortunate for this patient, which was referred to us from a surgeon, and this is the several options that we can deal with.
Yeah, there's nothing like a fake heart surgery to make a patient feel better.
All right, great. Thank you, Moody. Appreciate it.
Thank you.
Great case. So we'll move on to our next presenter, Dr. Marvin Ng, who's going to be talking to us about transcatheter replacement challenge.
Well, it's a real different from that, but the subject of replacement may come up. So these are my disclosures. So our patient's a 44-year-old gentleman who's got end-stage renal disease who presented with class 3 symptoms and severe heart failure with mitral regurgitation. And it was interesting because a year prior to the presentation, he had a bout of uremic pericarditis, was treated with pericardocentesis and dialysis. And then he's had a history of CLI against a background of diabetes. He's got a history of coronary disease. But he had just transferred from a hospital, like a month-long hospitalization, where he presented with necrotizing fasciitis, required an amputation, had MSSA bacteremia, which involved his mitral valve. So what we're seeing is kind of the sequelae from this, fasciitis and endocarditis. And this is a TE that was performed at the outside hospital. So you can see that there's obvious regurgitation, but it's not, in our opinion, really from the valve. It looks like there's been, some kind of necrotizing process that's, affected the mitral annulus and kind of like, eaten through the posterior annulus. But the valve we thought was actually preserved. And here's a coronary angiogram as part of his workup, and you can see, well, you actually can't see the LAD lesion, but in this ventriculogram, it actually gives you a better impression of what the makeout of this, endocarditis-related pseudoaneurysm was. So, CT surgery felt he was not a candidate. Well, that's the truth. And, what should we do next? What is the lesion? I don't know what to call this thing. It's just, it's eaten out abscess. So he, had at this point been sterilized from his infection. Surveillance cultures were negative. And, can you replace it? Can you repair this? How do we approach this? So of course, we start off with more detailed volumetric imaging. And I know this is moving really fast. I can't really control the scroll to look at in slower motion, but you can see kind of a profile image of this pseudoaneurysm. And what's interesting is you see kind of this eaten out abscess and the remainder of the posterior leaflet there. And we made some measurements, got an impression that the widest dimension is like 32 millimeters, but there's kind of like a neck to it, and the neck looked like it was like 12 by 15. Anyway, we took some more images, and here we have some 3D imaging just to get a sense for where it was. So you can see it's kind of on, the lateral side of maybe, P2, but it certainly dissects backwards towards the annulus. So, the serendipity, I don't know if you saw the title, I think is because I think he has some of these cardiac structures intact because he probably has some inherent pericardium from his uremic pericarditis. Yeah, it saved his life. So how do you approach this? What are the interventional tools suitable to repairing this if he's not a surgical candidate? Well, we just felt that the most coaxial route to this lesion was transapical. And we intended to fill the pseudoaneurysm, seal the breach, the combination of coils and a self-expanding nitinol occluder, which was our initial strategy, and it actually worked out. So here's a ventriculogram. And of course, we obtained this angle from the CT planning. All right. So we had surgical access through a small thoracotomy. Used an 8 French sheath, and it's a terminal destination. And we're able to navigate through the breach of the old abscess and into the pseudoaneurysm with a combination of a JR4 diagnostic and glide wires. So you can see the echocardiogram of a wire traversing the breach into the left atrium across the perforated aneurysm or the abscess, and a wire into the aneurysm posteriorly. And so that's a prograde catheter, and it turns out the penumbra makes these 60 millimeter coils. I know that some of the peds cardiologists use it, and we used about 14 of them, 13 of which are 60 millimeters long. And at this point, we're like, okay, it seems like it should be enough, right? And we resolved to use muscular VSD, and we had some debate. I really wanted to use a Gore-Tex device, but I didn't have the confidence that the device would lock appropriately and span that distance. So we just went with a safer decision and used a muscular VSD. And we're done, right? Here we are. Well, it turns out, we'll let this T play, and you see there's still flow and there's still some potential space in there. So it turns out we, let the patient go back to the floor, and he has hemolysis, which was one of my concerns with using a VSD device. Not the first time we've seen this. And what should we do now? And we thought that on the TE that the potential space inside probably opened up more because there was still flow. So we resolved to take him back to the cath lab. And this time, we didn't have the luxury of using transapical access. I didn't really want to access his thorax again. And there was just, there's some healing pledgeted sutures at the apex. So we resolved to go through the atrium, literally. We set the Bovie at 30 watts. I thought it was going to be enough. Using a Stato wire to access the potential space, and follow back in with a prograde wire, and this is all supported with the GR4 guide, and then advanced the prograde catheter, and with 24 more, most of them 60 millimeter coils, we packed that thing as well as we could. Let's put it this way, they're made of platinum. All right, enough said. And we're just lucky that that thing, whatever that is, if that's a coil, it didn't embolize. So eventually the hemoglobin stabilized, and the transfusions decreased and eventually stop after about 2 to 3 weeks. So what we learned was, history, and comprehensive anatomic analysis was very important. And you really have to have a broad bandwidth of therapeutic options. So, we learned a lot from our cardiac surgery colleagues, our IR colleagues, and our vascular surgery colleagues. So, I didn't know about those 60 millimeter coils when I finished training, and maybe they didn't exist, but it's, like conferences, talking to your colleagues, seeing what they do, that's how you grow, and always be willing to re-examine what you've done and if you failed, because it's important to end up with success.
Marvin, that was a great case, tour de force, and certainly quite an expensive case too. But I guess one of the questions I had, you were able to successfully navigate towards the defect transeptally. So now knowing what you know, would you have felt like you could have completed the entire procedure if you went transeptal?
I think so. Yeah. It's hard to know because, what we were concerned about is we don't understand the integrity of the tissue, and I have to assume from people who have actually handled it before that there's not much. Right. So I just had to trust that the best way to approach it is be as coaxial as possible and manipulate as little as possible.
Yeah.
Just if you could, all the imaging you did, can you just clarify what you think, in retrospect, the initial lesion was? Was it an LV pseudoaneurysm with to and fro flow, or was it actually a fistula, kind of a perivalvular fistula that connected LV to LA? Because it was hard to tell.
Are they different?
Well, pseudoaneurysm is contained. It goes back and forth through a neck, where fistula, connects two chambers.
Well, I think it was a pseudoaneurysm, and we think it's an old abscess that had been basically eaten through and was porous into the left atrium. So maybe that's the fistula, and there was a pseudoaneurysm that was going into, I guess, what was the angular structure, but it was held together by an inherent pericardium.
That's what I think it is. I mean, if I had to think about what it is, surgically we've approached these patients, of course. I mean, being on dialysis or having uremic pericarditis is not a contraindication to surgery anyways. But when you patch these are all annular abscesses. So he's had endocarditis and it's buried out. The reason it didn't blow out and die, which we'll see in some people, is because of his pericarditis. And then he formed a pseudoaneurysm right there as it lifted up. We could have done it cheaper, actually, I think.
I'm sure you could have.
Marvin, a quick question. Why did you consider a VSD plug rather than like a 16 or 18 AVP, which causes less? And then in that case, like when you put a VSD plug at the end anyways, would you have still considered coils, considering some of these pseudoaneurysms we put plugs in,
Right.
and then they.
I mean, it's a good question. Like, if you use a VSD, it doesn't have cloth in it. I'm sorry, I'm saying if you use an AVP, like an AVP2 plug, is that what you're referring to? So it's hard to know. Like, my feeling, or maybe I'm wrong, if you don't want to get hemolysis with an AVP2 plug, it has to be compressed enough so that the weave inside of it is too small for cells to pass. And I just don't know if that tissue has enough integrity to withstand that level of compression. I mean, this is all, conjecture, right? Knowing what I know, maybe what I would try it harder to do is actually use a Gore occluder and then try to lock it and then recapture it. That's what I wanted to do initially, but when I was at the table, I got a little nervous. I was like, well, what if it doesn't lock and I have a hard time recapturing it? So I just went with this, what I knew what I could recapture easily.
We're talking about a 25 or 30 millimeter disc that would be on the surface of so that you could interfere with the mitral apparatus.
Sure.
There's a certain risk of using, AVP2 I think sounds better than using either a Gore device or an ASO. They work beautifully for aortic pseudoaneurysms, but here I'd be worried about subvalvular interaction or even mitral apparatus interaction.
Yeah.
So we had a similar case, but in post-mitral valve repair surgery with a pseudoaneurysm, and it was really large. The biggest concern after we coiled it, and it was very similar. So we had a similar case with a pseudoaneurysm in this to this case here. And the biggest concern after we had coiled it with a lot of coils is some residual coil was left outside and coming out.
Yeah.
And it was a big shock to us because when we initially packed it, it wasn't there, and then came out. And the concern was, are you going to start to embolize? Are you going to start to form clots and do that? But going back to literature, especially from the cerebral aneurysm literature, we found that it happens up to 20% of these cerebral aneurysm. They have some residual coiling coming outside, and as long as the patient on anticoagulation for 6 months, it tends to be stopped. And this patient actually had repeated imaging with TEE and CT scan after that, and for some reason it stopped moving and it kind of resolved completely by itself. So this is something that we learned also.
Yeah. I mean, it's the particular reason why I use such long coils, because I've thought that if most of the body of the coil was within the sac, that the opportunity for that occurring was going to be less. But we're kind of learning. It's
the same battle because you want to fill it completely and prevent any flow. At the same time, you don't want to overpack it and start to come out. So the same thing.
Just a question, Marvin here.
Yeah.
Did you consider a retrograde aortic approach coming through the aortic valve and going around to access that pseudoaneurysm?
I've thought about it. I was concerned that I wouldn't have enough control. So because even though they're detachable coils, which is nice, I wanted to make sure that if I'm using things that can embolize as easily as a coil can, that I have full control of what was going on.
Great. I just looked up on medicalecart.com. 6 by 20 is $3,999 for a box of one.
Each one? For each one. Guys, that's what. So when you burned across from the atrium across the side of the wall, how did you know where to go?
Well, we used echocardiography to target us. And I made sure that the guide was orthogonal to the atrial tissue at the site where there's a cavity, and then I kept the burn short, right? So I tried to minimize the amount of impact. So as soon as I thought I was across, I just kind of pushed the wire on its own, and then we could see it through TE using biplane imaging, and then after that we were in, then just advance the catheter.
Gagan, I just looked it up. A 3x5 bovine pericardial patch, $39.
Okay, fine, you win.
There was no contest from the beginning. Come on.
Well, can we cancel Wi-Fi for next year so nobody look anything up? Well, next is a colleague and friend who I personally learned tremendously from him, who's going to talk to us about surgical knowledge that helped in transcatheter use. Moritz?
Thank you, Firas. Thank you for the invitation. It's great to be here, Paul. Really lovely. And I've learned a lot this afternoon. It's a great session. So I guess I was asked to comment on why surgeons should still be part of transcatheter mitral valve interventions. And these are my disclosures. Before, I'll promise to show an ultimate case, like the penultimate ultimate case. But just wanted to share a few thoughts where surgical knowledge really helps, I think, in the process of working patients up for doing transcatheter mitral valve procedures and then going through with them. Patient selection is an obvious one. The morbidity, mortality with surgery, most can do with calculators and some knowledge. I think the durability of repairs and expected outcomes, especially with re-repairs, is a tricky one, unless you do have experience with that as a surgeon. When we are willing to take on MAC and concomitant disease, I think these are important consideration. The challenging anatomy also maybe seems like an obvious case, but I think that applies more to the less experienced operators, where we as surgeons may have a little bit of an advantage because we know the anatomy from looking at it often. And then real-time decisions on changing strategy once you're going with the transcatheter case, and there may be a good reason to abandon that strategy and go to surgery to save some coil money, for example. So with that, just sort of the general thoughts on this, I did want to present an ultimate case. And this was a 64-year-old lady that presented with severe dyspnea, evidence of hemolysis and NYHA class 3-4, had several decompensated congestive heart failure episodes. Several years prior had endocarditis where she got an AVR with a 25 millimeter mosaic valve. So clearly this was done in Michigan, because if I understood Steve correctly, he only puts 25 millimeter valves in. So, sorry, okay. And the lady was not completely not considered for surgery. This was certainly a discussion. I think a few thoughts here, home oxygen, essential frailty tool set of 3 out of 5 points, so frail. And then really the driving factor being severe MR. Would be a little bit a different story if it was predominantly mitral stenosis, I think. Patients that have a small valve like that, you can only expand the transcatheter valve inside of it so much, so you have to be cognizant of that. There's a small PVL, another consideration. If you can think you can get away with closing that small PVL with pushing sort of the surgical valve to the side and close that at the same time, if you will. So we did the usual workup, CT analysis, and I'm showing this for a specific reason, but that's part of all the TMVR workups now. If you look at the image on the right-hand side, the area was 222 or 32, I believe. Yes, 32. So certainly not in an area where we would be super concerned about having LVOT obstruction. As mentioned earlier in the session, below 200 usually is where you start worrying about this. So we felt this was an adequate candidate for this, and certainly an option for her to move forward with transcatheter mitral valve and valve replacement. So here is the deployment of the valve. And there's at most some style points I can make. That's not what I wanted. There's the valve. Oh, I keep hitting the wrong button here. I want the laser pointer. There we go. So the only side point here is probably that the pusher is a little bit far back. You really want the pusher further forward, so you have sort of pushability to get coaxial. I really thought the comment on using a sort of reverse curve was really nice, and maybe we'll try that next time, but this is the only style point I have for this. But it was a nice deployment, went well. But then we did end up with a small PVL. We had started out with a small PVL. We had started out with evidence for hemolysis, so we really didn't want to leave this behind. So well, we decided to post-balloon this. And the images are a little bit choppy, but we used a 25 true balloon here. And anybody wants to take a guess what happened next? Firas is either sleeping or very focused on that image. All right, I'll spare you the comment.
I think I know. I think I know what's going to happen, but any.
Well,
any
now you
comments?
should know.
Okay, now I do.
Yeah, so, well, the problem here is obviously that we ripped the valve. So not a great sight. Torrential MR after post-ballooning this. And I think it was interesting to hear the comments in the conversation about using a 23 versus a 20. Yes, absolutely, please.
Why did you dilate this? That PVL was there pre-op. You're not going to be able to dilate that.
Yeah, but we had used post-dilation to get rid of some of the PVLs.
But I think the PVL was outside of the surgical housing, not inside, between the surgical housing and the TAVR.
Right, so the idea was to expand the ring and
Smash it out there?
yeah, yeah. So, it's the alternative here would have been, and I think that's a fair comment, the alternative here would have been to do a PVL closure, probably beforehand, and then put the valve in. So I think that certainly, in hindsight, definitely would have saved a lot of headaches here. So we did that, and that was complication number one. So coming back to the comments on using a 23 versus a 26 millimeter valve, a lot of this work on over and under expansion of valves has been done by Zahr and the Vancouver group, and this is from one of their papers showing what essentially happens when you overexpand a 23 millimeter valve. Over, under expansion, asymmetrical expansion, all has consequences. These valves are supposed to go up to the exact dimensions they were designed for and be round in shape. So the patient did not tolerate that well. Despite having MR to begin with, the acute MR did not sit well with her. So really the quickest bailout here was to put another valve in. Someone wants to guess what happened next?
So now your guess for LVOT is a little off.
Yeah. Yeah, so that's exactly it. So now we're stuck with a valve in valve, turning the first transcatheter valve in a tube graft and essentially creating a significant LVOT obstruction. So in the end, it was good that there was some surgical expertise available. So took out the valve in valve. And so again, what you see is the first transcatheter valve being turned into a tube graft. I think it also shows the underexpansion. For the acute setting, you'd rather not have this kind of ruptured valve and deal with pinwheeling. But I think in the long term, pinwheeling is probably not a great thing either for these valves. So clearly, again, speaks to the issues of underexpanding these valves is not maybe as trivial as we think. So valve-in-valve TMVR is, generally safe and is now fairly commonly done with reasonably good results. But there's, certain tricks to the procedure. And as this case clearly shows, it's not the first mistake that gets you into trouble. It's the second one, or the lack of an option at this point. The smaller transcatheter heart valves are less scalable. I think really the overexpansion of the smaller valves has much greater consequences than the larger valve sizes, but I think in general is not a good thing for these valves. And then LVOT obstruction obviously is a bad problem to deal with, and in hindsight, having known the both the frame and skirt neo-LVOT, would they have changed the management? I think we were sort of trying to get a second valve in to save the patient from further decompensation because of the acute MR, but clearly left us with another big problem, which was LVOT obstruction. But bottom line is, interventional cardiologists and surgeons should collaborate and not just be there to bail out, make these decisions together. I think for interventional cardiologists, it's good to come to the OR and see the anatomy and see what we do. Thank you.
Nishtha.
Great case, and props to you for sharing such a complex case. And I would just add, I just wanted to add one line to your last part of that slide. I think the imaging colleagues too, particularly need to be in that conversation. And I think when you have that true heart team with the imagers as well, really, really, truly, for some of these complex cases, makes all the difference. Because as several folks pointed out, that leak that you had that was paravalvular was really with the prior surgical, and that could have changed management had that been assessed.
Yeah, I think it's good for everyone involved in these cases to really understand the other side, so 100% agree.
I think everybody in the room needs to know that a porcine valve, which this is, and a bovine valve will present with different failure modes. So everybody needs to know that in the cath lab, that a bovine valve presents with slow mitral stenosis, whereas a porcine valve actually calcifies and rips itself and will present with mitral regurgitation. So I think everyone needs to know that's a different presentation mode. We put in bovine valves because I'd rather have the patient slowly get sick than suddenly get sick like this woman did. So the second thing is that this device, the Mosaic device, the stent legs are notoriously flimsy, and actually when you tried to overdilate it, all you did was, if you saw what you were doing, you just overdilated the front end of it and you didn't put any force on the base. I'm not sure you could have closed that PVL anyways, but that's what happened, and that's probably why you tore the valve. But
Yeah, I think both really good comments. I mean, I've personally moved away from using porcine valves for both aortic and mitral position for that exact reason. If those go bad, they usually are pretty acute how they present. I'd rather have someone who slowly develops stenosis or, all this. And then the other point is very good too. I think there's this concept of flaring the sapien valve to prevent it being kicked back into the atrium. But there's so much as too much of a flare, and this is clearly what happened here. I mean, it's just because, as you explained well, the stent posts are so flimsy. And all that happened is just ripping those commissures further apart. Yeah.
I mean, the last thing is now most surgeons are really thinking of planning for a valve in the future for these patients, valve and valve. And we've clearly dropped our age down. One of the bovine valves, we just reported at the ATS 1,700 bovine mitrals that last actually quite much longer than we used to think they did. And the second thing is plan for valve and valve with the patient. So don't put a 25 in anybody if you can. I mean, sometimes you can, obviously, but try not to do that. That's our thinking now.
Firas, I have a comment.
Just one question for the panel and the audience who've done some of these. We did one recently, and we were deciding what to do in terms of the PVL. Should we deploy the PVL first and then do the valve and valve, or should we just wire it, have it ready to go, do the valve and valve, and then do it secondarily, but we were worried we may not be able to cross. So we did the PVL closure first, and then we deployed the valve, and then we completely deformed the PVL device and actually shifted, and then we had basically a disc, completely moved, the PVL came back, and then we had to bang on it from the chapter, and we were able to kind of push it back through the position that we intended, which was just completely a stroke of luck. So I'm just wondering, what are people's strategies?
So yeah, actually, I was going to comment on that. A great case with a lot of learning points, and the question, since you didn't have a mic, I'll just repeat for everyone, is what to do with the PVL, considering wiring it beforehand or afterwards. And what I've always done is we'll put a wire in beforehand and just have the wire there, and then you do the valve and valve, and then you assess, because sometimes you'll get a little bit of movement, but usually that PVL didn't go away. You have an old surgical valve with tissue defect, and expanding it, moving it, doing anything is not really going to change. It just moves the tissue around, and that PVL usually doesn't change. But having that wire there already when your imaging was fresh, when you don't have that cage in the way, it's just easier to get the wire in there, and then you can put the plug device in afterward.
If we wired it first, worried that if we didn't, we may not be able to cross. It would just, should we deploy the PVL device before or after deploying?
Yeah, after the sapien would be, yeah.
Well, we did actually, we didn't fully deploy it. We didn't fully release it. Right, and that's why we were able to reposition it.
Yeah, I mean, I completely agree. I think it makes sense to put a Platinum Plus or something down there just to have their track. It's much easier to wire it that way. It brings up the question, because you deform everything, are you still going to size the same way? And the answer is probably yes, because that's the best you have, but yeah.
So we would take a different approach. We wouldn't do anything to the PVL because you don't know that a hemolysis is coming from that PVL. These porcine valves get a bunch of calcium on there. It could be hemolyzing off that valve. We'd put a new valve in, come back in a month and reassess and see if that's actually, because that PVL wouldn't hurt her. Every PVL is not bad. A little tiny PVL, we just leave. It's only if they're hemolyzing that they get into trouble. So we'd put the valve in and come back in a month.
Firas, a quick comment. From a surgical standpoint, you said, you don't like porcine valves, but porcine leaflets are about 50% shorter than the bovine leaflets. So it has a much lower risk of LVOT obstruction with a valve-in-valve. Like, you know, the new LVOT we calculate is for actually bovine valves. For porcine, like, they're much shorter.
Yeah.
And I go up to 150 even with valve-in-valve, and it works well. But again, you know, when we're looking at for future purposes, like, how do you balance that?
I think that's a little bit of Abbott Kool-Aid, but
No,
you
it's
know,
a-
I think
I see
Edwards valve now has a lower frame, stent frame.
The new Mitral valve has very short legs on it. And
So-
remember,
so
we mount them up into the atrium anyway, so I think that's not true.
Yeah, the other thing about redo mitral valve, if you are getting these patients back that have these small mitral valves in, when you reoperate on someone, you can always get 2 sizes bigger than the original surgeon put in, for whatever reason. When you cut that out, it goes up 2 sizes, and the person's going to get a lot bigger valve and take care of the problem.
So Maurice, I think the valve-in-valve mitral is becoming mainstream. Is what most of us do right now for failed bioprosthetic mitral, especially for the first time the bioprosthetic fail. If you have to do this case again, what would you do differently? What stages do you skip? The post-dilatation, the PVL, both. I mean, how should, because having a tiny PVL is not uncommon. Actually, having a PVL in the mitral or a ring or whatever you do is not that uncommon.
Yeah, I mean, it's a good question, right? So hindsight 2020, and I think perfect is the enemy of good. So I think we're chasing after that PVL more than we should have. We should have just left with what we had with the first valve, and we would have saved ourselves a lot of trouble. The PVL, as you all know, it's there's tiny PVLs that won't matter. They will even go away. And then there's the small PVLs, which are really going to cause hemolysis. Now, that's not an emergency, and so, I think it's not unreasonable to come back later and deal with that, and maybe even better. So I think the mistake here was to chase after that PVL and try to make it better.
How about for the hemodynamics? I mean, you have a 25 mosaic, and it was a 23. Do you think that justify?
I mean, that's you're just. That's what you're stuck with. And, I think it's a little bit dangerous to say you will always get 2 valve sizes bigger in. Not so sure. Wondering what Steve would say. Actually, I think that was a reason here to not push for surgery either. Small lady, 25 millimeter valves. Now, yes, we all stand up here as surgeons and say all these other surgeons just put small valves in. I never put this in, but the reality is if you look at the data, that's not true. And there's limited things you can do to upsize on the mitral side unless you're also going to do the aortic. Then you won't have a problem. You can put in as big a valve as you want. That's really not an issue. On the aortic side too, it's never an issue. I say I never put anything less than a 25 in, and I can stand behind it because I'm just doing root enlargements on everybody. It doesn't, that it's fine to do that. In a mitral position, you don't have that option really. And I think, 25 millimeter valves do go in, and you're stuck with that landing zone. There's only so much you can do to expand it.
Great. Thank you, Moritz. We're
So
running
if
out
I
of
can
time.
just quickly comment on that, I don't think you can upsize these very much. I think if you go back in a valve that's 14 years old, that orifice is fixed.
Yeah.
And you got to put the same size in. And I have put 25 valves in there, but that's only because they have calcium in there. I cannot get anything bigger in there.
All right, so that was a great discussion, great case. Thank you for sharing. So we'll move on to our next presentation by Dr. Anene Ukaigwe, and she's going to talk to us about a new transcatheter repair boundary that's crossed.
Good evening, everyone. Thank you very much for inviting me to this. And this will be titled One Bad Turn Deserves Another and Another. Oh, I guess it's the end. Okay, I have no disclosures related to this talk. So this is an 86-year-old lady who was referred to our team for evaluation for mitral regurgitation, has heart failure with mid-range ejection fraction, related to previous revascularizations, so ischemic. Over the past few months, recurrent heart failure hospitalizations, now hypoxic requiring oxygen. An attempt at escalating her medical therapy was met with hypotension. Her right heart catheterization showed a moderately elevated right-sided filling pressures with preserved cardiac output and index. She had no new obstructive coronary artery disease, and a PFT showed restrictive pattern. So this is her TEE that shows at least moderate to severe mitral regurgitation with an enlarged left atrium and morphology that was more consistent with atrial functional mitral regurgitation in keeping with her atrial fibrillation. And we can see that she has a mean gradient of about 3, but in the top middle panel there, she has lipomatous hypertrophy of her interatrial septum. After a heart team discussion, we all decided 86-year-old functional treat. And so this was an attempt where we started the transeptal, and I am lucky to train fellows, and now I understand how the people who trained me used to feel. So we started this transeptal. Our height was about 4.5. We were comfortable with that. And on the left panel, we're crossing with the vessel cross wire. In the middle panel, we see what the trajectory of the sheath is. And just before the one on the right, I hear Dr. Ukaigwe, I cannot move the guide across. And so I take over and I decide to try. And that's me trying. I still could not get it across. So the question is, why do we now have this difficulty? So it looked like we had crossed at the edge really close to the very thick portion of the interatrial septum. We had probably slipped but just before we had burned across. And at this point, should we do a new transeptal or should we just keep going? Anybody?
You look very anterior, and you can start seeing a little bit of the anterior mitral leaflet. So I think even if you do get it across with ballooning the septum, you're going to have height problems.
Where were you when I needed you? So I go with a balloon atrial septostomy, and I can see from that balloon on echo that that's a really anterior trajectory there and a bad aorta hugger. But I'm like, we have maneuvers for this. I can get across. And so I proceed after the septostomy. I can get the guide across, and we see that we really do have that bad aorta hugger. And eventually, that's the guide popping across very anteriorly, and we can see how anterior it is because it's pretty close to where the LAD stents are. And after that, so aorta hugger correction, easy. Plus nub, you go posterior. A nub, you go anterolateral, medial to correct that lateral curve. So here we go. And by the time I'm done, I'm right beneath the valve and I'm caught on the subvalvular apparatus. So at this point, I eventually get myself out. There's now worse mitral regurgitation, and the bottom panel, we see that there's something flicking there, so I had injured one of the cords there. And in the room, this is all the conversation that is going on now. Should we abort or should we do another transeptal? So the first one was the clinical support. I have never seen an aorta hugger this bad. Dr. Ukaigwe, we should abort. The middle one was my imager, who is a heart failure doctor, who said, we can't leave her with this worse mitral regurgitation given how she came. And the last one was the fellow, Dr. Ukaigwe, maybe we should do a redo transeptal, but what's the guarantee that we're not going to end up in the same place? What is missing here is a cartoon of me screaming in my head, get me out of here. And at this point, thinking about it, that aorta hugger correction, with that plus knob, that was when I said suspecting that my height was actually way lower than I thought it was. And that plus knob probably just took me right across the valve, and that's why I ended up in that position. So I asked to see the images again, and that's about my transeptal height. When I remeasured, it was less than 3. And so what do I do now? So I decided to gain height.
Tell the fellow to leave the room.
And so the thing here is that fortunately, the correction is similar, except that the plus knob was going to counteract what I needed to do to gain height. And so what I ended up doing was take the guide as posterior as possible, and then just use the A knob and the M knob to correct my trajectory. And with that, fortunately, the other part is that most of this jet was more lateral than medial, so that was also helpful. And so we took this height that was about 2.8, corrected the aorta hugger. This was one grasp, and done. Mitral regurgitation eliminated, gradient of about 6. And the key learnings here is that to be a good edge-to-edge repair operator, it's key to understand the steering maneuver techniques and what the tools are for management of unfavorable interatrial septum. Finally, a follow-up. I saw her personally in about 4 weeks. She was off of oxygen. The diuretics has been de-escalated. She was no more hypotensive. And this was predominantly for a quality of life benefit. She was back to activities with her friends. So I was going to say that this is similar to what Dr. Rishiadi presented, but I mean, if my ultimate case is similar to Dr. Rishiadi's, then I'm on the right path then.
Anene, congratulations on that case and bailing yourself out. And really, you just expertly demonstrated how mastery of knobology really kind of helped you there. I'm curious about if you had to go back, would you have just retranseptaled and started over? Because I think for mitrals, you know, it's always sort of that temptation to kind of continue on. And I think sometimes in our field, we sort of say, oh, well, I can kind of bail myself out versus just taking a breath and saying, nope, let's do this the right way and starting over. And I guess the other follow-up question I had is for the panel as well as for you, but in the conversations that we've been having and in the era of being mindful of economics, sort of I'm curious how many systems have completely shifted to radio frequency for the transeptal system versus more traditional equipment?
Thank you very much for the comment and question. So the first thing was, the answer to your question was the last slide that I showed. Good experience comes from, from bad judgment, and bad judgment leads to better experience. So I think if I looking back right now, knowing what I know, I should probably try to re-stick before I went up with the guide. And that way I wouldn't have to keep trying to do multiple maneuvers. But the thought was, with that very thickened septum and just a small narrow window, we may have still ended up with the exact same or something similar, and ended up with a similar scenario. And just to give you a little bit of background, just before this case happened, there was another similar case that had happened, and trying to avoid or trying to cross an interatrial septum that was that thick actually led to pericardial effusion, which was part of why we're like a little bit more careful with that. And the second part is, with electrocautery, my partner doesn't use it. I do. A couple of my other, and one of my other partners does. I think it's like way easier. You have a lot more range of septal difficulties that you can traverse with that, and I think that maybe justify the cost of doing that. And ultimately, if you're not using that and you need to bail yourself out or need to do something different, you're going to end up with electrocautery anyway.
I'll just make an imaging comment. So, even with really solid tenting, of course, sometimes the needle or the cautery can slip, and you may not feel the slip. So we, for the last 200 or so consecutive cases, our routine is to look en face in 3D. So we look from the LA, you see the tenting, everybody confirms that you're between 12 and 3 o'clock on the fossa, and the beauty is with variable gain, you can just turn down the gain, the fossa gets really big, it's very clear where it is, even with a lipomatous hypertrophy of the septum. So our routine is to just en face 3D, see the tent, and we actually do the cross in that view. And I think it's really hard to be in the wrong place if you're watching it real time.
Yeah, I think that last comment is key. Just watching it real time is very helpful, because you sometimes just can't feel that needle slip.
Thank you. I'll take that back to my team.
The hardest part about that approach is for the interventionalist to wait for the 3D to get set up. But with practice, after 200, I'm sure it happens in like 5 seconds now. But same with us. Initially, it took a couple of minutes, but now it's down to seconds. But it definitely is. I agree with that. So, All right, so we'll move on to our final presentation before we close the session. Thank you. So to Dr. Elana Koss is coming up, and she's going to talk to us about a case of why you'll always need a TE for mitral therapy.
All right, thanks for having me. You are very brave, I will tell you that. I would have asked you to redo this transeptal, but that was an awesome case, so thank you. All right, so thank you, Paul, for giving an imager who only uses TE to do mitral tear therapy to present this topic. So really, the question is TEE, the best imaging modality for mitral tear? Well, the question really is ICE ready for prime time to guide these cases, not just as an adjunct, but as a sole thing. So when you're thinking about using a new therapy for something that you're really, really good at, right, you have to demonstrate a need. And we are really good with TEE at doing mitral tear. Right, we could do the whole case, we could drive the entire case on 3D, we could see the transeptal, we could see your trajectory, the whole thing, and the imaging is just so good now, and we're so fast at doing it. We could do a case 20 minutes, and we could do really complex anatomy. So what's the appeal of ICE, really? So no TE required, okay, so you won't have esophageal trauma. The idea that maybe we will do these cases under conscious sedation, the ability to park an image, well, honestly, we do the same thing with TE. And a sense of independence for the interventionalist, right? Like now I could control the whole thing. I'm not sure that that's really quite the case. And the ability to perform mitral tear on patients in whom TE is contraindicated. And there's a group of these, but I think that the mini TE might be useful here in the future. So, what are some of the challenges with ICE? Well, there's a learning curve for the catheter manipulation for the interventional cardiologist. And now there's a whole new layer of communication between the interventional cardiologist and the echocardiographer who's running the console. So now you're not only talking about how to manipulate your clip or your device, now you're talking about how to image as well. So now you have 2 layers of communication that are really, really important. You may require a second interventionalist or other operator to manipulate or stabilize the ICE. You still need your echocardiographer for digital steering. You could get shadowing from the tear device, from the ICE catheter, and not be able to see. I mean, TEE, you have just so many options in optimizing your image, and there really are less so with ICE. There's a risk of intracardiac catheter manipulation. You might have to do a second septostomy, or at least dilate your initial transeptal. You have to have a second site of access, usually from the ipsilateral or contralateral side, and obviously these are very expensive, right? So in your 10 ICE cases, I could get myself a new X8 probe, which I would love to do. So really, what is the difference, right? Why do we have these differences in imaging? Because if the imaging was the same, this might be more appealing. So, you have many more discrete elements with the X8 transducer and the Verisight, and I'm gonna compare this, Philips to Philips, right? So we're using the same machine and the same software, right? So the Verisight transducer has fewer crystals, but not only that, you really have a smaller window to get your best resolution. So your omniplanes are really between -60 and +60, because that's where you have the largest aperture, the widest aperture, and that's where you have the best resolution. So that's really something that's important to learn, and we're in the process of trying to learn that and get good at that. So I don't know about how all you guys plan your mitral tear cases. We do a lot of pre-case planning in the room. We do not always have a TE on these patients before, and sometimes even when we do have a TE on these patients, we do change our strategy depending on what we see and on additional imaging. But if you're bringing a patient in who hasn't had imaging, you're now pre-case planning in the room. And we like to get all of that over TE in the beginning of the case. Well, now you got to wait for the ICE catheter to go up, and now you're going to look at it, the mitral valve through the right atrium. Well, I get to look at the mitral valve from the esophagus right into the left atrium. I mean, it's really nice and clear. So if you could just look at, you could see there's really a difference in the 3D imaging. And we'll plan our whole case on, just using MPR with a good 3D image. Next slide. But the nice things that you can get from the right side with your ICE catheters, you could see the left atrial appendage, you can get gradients across the mitral valve, you could look at your pulmonary veins, and the color Doppler is reasonable, it's okay to see. Just to know, you don't have deep gastric views with this, and we do use our deep gastric views to get a hemodynamic assessment of these patients. So transeptal puncture, you really could see this, you're imaging in the opposite way, right? So from ICE, you're seeing the left atrium mostly. When you image with TE, you're seeing the right atrium mostly. Well, we're doing our transeptal from the right atrium, and sometimes it could be hard to see it, and I think that you see in the image above. You could see the dilator going across in the bottom left, and you could see your wire in the left atrium in the bottom right, and these are all with ICE. So now you need to advance the ICE catheter into the left atrium. The Verisight is actually the smallest of the 3D catheters available, 3D ICE catheters available. So in that case, this is one that we tried to do and use the same transeptal, not do a different one. And here we tried to dilate the septum by kind of flossing the guide a little bit, and then you have to get the ICE catheter across, and that's like kind of a moment of blindness, like us imagers, we want to watch you the whole time, and not like we can't see for a little bit, and that makes us a little bit nervous. Your SGC insertion, so the ICE catheter is sitting in the kind of the roof of the left atrium. It could sometimes be difficult to see the guide across, like we like to watch to make sure you're in a good position with your guide. But you're really able to see the CDS insertion. You could see getting down to the valve. But on TE, I could sit there and watch the whole thing on 3D. These are just comparing some of the images, and I will say this: I think on both sides, both of the imaging could have been optimized, both on the ICE and on the TE. But you could see that now you're in the left atrium, and you're like, okay, now I'm going to assess the mitral valve. I'm going to do my clip selection now, and that's really hard on some of the 3D imaging. So 3D color assessment is really not there with ICE. And for us, that's really, really important, not only in assessing these patients before, but assessing afterwards. It's like your best opportunity to quantify mitral regurgitation is with the 3D. And then we use the 2D, we use our transthoracic. The next day we have now like a correlation between it, and it's our best quantitation. So the technology is really, it's just not there yet. Really, you could do all this with ICE. You could do your device orientation, your trajectory check, your MPRs, and your biplane. But like this, I'm not so comfortable with this. I want to see the leaflets. To me, the most important thing in TEER is seeing the leaflets, and if I can't see them, I'm really uncomfortable. So to me, like this is something that I'm not so comfortable with. And again, I'm not showing you the perfect, most beautiful A+ cases, but these are cases that my colleagues gave me that I think reflect kind of a real life experience. And obviously, we're going to get better with all of this, right? Even in using the technology that we have now. You could enter the LV and you can grasp, you could see, ICE versus TE, and I would say that TE image itself is not even optimized, but just look how the resolution is just so much better, right? So this is not just the temporal resolution, but it's the spatial resolution. So you could see nice frame rates even with ICE, but the spatial resolution really is not always there. Then you have your post-deployment assessment, which I think is okay, and the color Doppler is also okay too. Again, like we really love to use 3D, but I think this is fine, and you can move your X-plane and really assess the leaflets if you wanted to put more. And again, this is kind of what you have afterwards on 3D. So I think that TE is here to stay for mitral TEER really at this point, but we need experience, and we're all going to learn together in this space. And I think we're all trying. The degrees of ICE manipulation are just less. Like we could just really do a lot more with TE to optimize the imaging. And remember, you have 2D imaging, it degrades when you go to biplane, and it's even worse when you go to MPR. So you need really, really awesome 2D images if you're going to use your MPR. 3D color is not there. You can't really pre-screen your ICE imaging. You don't know before what you're going to get. It's super, super expensive at this point. I think that's really, one of the main issues. But that said, we're early on in our experience, and it's really important to learn ICE and embrace it. But I don't know that it's there yet in mitral TEER. I don't know if it's going to be, but I think there might be some more hope for the mini TE. But that's it. So thank you so much.
Thank you, Elana. That was a great talk, great discussion, and just happy to see a lot more kind of discussions about intracardiac echo and its role in structural heart. And I think, I don't know if Steve, you can comment on kind of its role in the era of TE and how people should adopt it. Is it a all or none, or is it kind of a more hey, I'm going to start applying it for my routine standard cases, and then ultimately try to use it as an adjunct in the cases where I think I'm going to have trouble with TE imaging.
Yeah, I think we need to embrace ICE. I mean, I went to medical school 100 years ago, and we had M mode then. That was like 1D, you know? And then we had 2D. That seemed like a lot of Ds. We had way too many Ds. And now we have 3D, and we have 4D. That's a ton of Ds. But I think we have to embrace ICE. I think it's, the one thing that I like is it allows us to do these under conscious sedation. This could be a day procedure. It really could. And the technology is going to get better and better and better. And Elana, you're right. I mean, right now the resolution is crap. You know, face it. We can do it, but it's sort of we get away with it because we can do it. But I think it's going to, the technology of the pixels and the AI, the math behind it will be really good soon. And I can remember doing our first 3Ds where our guy would come to the OR, Bill Armstrong would come to the OR, and he would make a 3D, and he'd take it downstairs, and I'd go ahead and fix the valve. It was a P2 prolapse. I repaired and sent him home, and he'd come back to clinic in a month, and Bill would call me up, and he'd say, like, we got it, Steve. We think it's a P2 prolapse. Yeah. Thanks, Bill. And it's come a long way from then. I think this will get much better.
I'll just jump in and echo. There's a couple things on there. I mean, ICE is an adjunct, absolutely. The setup whenever there's a debate or something of versus TE is just not realistic. You know, TE is good. ICE is a tool. It gives a different perspective. Perfect. The vast, vast majority of people have a fully functioning, imageable esophagus. This notion that it's tortuous or, you know, bleeding, varices, sure, that, you know, that doesn't happen very often. So 99% of people who come for these therapies have an easily negotiable esophagus. So I think it's going to get better. It's super expensive. It's an adjunct. It is here to stay. But as we get mini T and these other things, the other, you know, that gets thrown out a lot is the conscious sedation attraction. But our CV anesthesiologists wake up everybody. I mean, you can have an endoscopy, colonoscopy, go home the same day. It really doesn't keep you in hospital, the sedation, by any stretch.
Yeah, I think part of the discussion about conscious sedation is not so much, hey, we don't like our anesthesiologist or they're doing a bad job. It's just the number of anesthesiologists and anesthesiology slots. And so, I mean, I read some number recently that the number of LAO cases is now surpassing the number of TAVR cases. And there's only so many anesthesiologists
There's a lot of CRNAs.
So I think, you know, again, it's a resource thing, and I think so at some point maybe that, but for other structural heart procedures such as TEER, TMVR, TTVR, et cetera, you know, ICE does not, and one of the misconceptions also out there is ICE will replace the imager, and actually it does not. You know, ICE, you actually need the imager even more, and because a lot of it is park and play, as Elana mentioned, you park it, a lot of console manipulation to get us the images that we need for TEER. So. All right, well, I think we're at the end of the session, and so I want to thank all the presenters and the audience and my co-moderating panelists. Thank you.